This good afternoon, sir.
Be recorded.
Okay, so I would expect everybody to switch off their mics, please. So today's lecture in two parts. The first is biliary dyskinesia, and the second is we're starting with gallbladder today. And I would suggest that the postgraduates, they should also attend the second part of the lecture. For them, it would be a good revision. If they know everything, just be a revision for about a couple of slides. Okay, so let's start with the biliary dyskinesia. First of all, okay, so this is basically a disease which is not very commonly understood, and already there are updates to the disease of biliary dyskinesia. Now, first, let's look at the clinical scenario presentation. Somebody's got the mic on. Please switch off the mic. Okay, so the clinical scenario presentation could be quite varied. One, it could be a biliary pain without any demonstrable pathology. The patient comes in, do all the investigations in this patient, don't land up with anything positive. Or it could be a biliary pain in the pediatric age group without an obvious pathology. We're getting more and more of children being afflicted with this kind of a pain. Children coming in the age of 5 weeks or even 10, 12, having this kind of a presentation without any obvious pathology. Somebody's got a mic on, I believe. Kindly check your mic, just put them off. This is still on with somebody. The third could be a post-cholecystectomy persistent biliary pain without any obvious identifiable cause. And this is what we commonly know as a post-cholecystectomy syndrome, part of the post-cholecystectomy syndrome. Yeah, I think that's better. So,
can you hear me now? Or the voice is
Yes, sir.
Was it some disturbance on my?
Yes, sir.
So
Yes,
basically, the third one is the more common that we understand. A patient comes to the cholecystectomy, keeps going back to in the OPD with this persistent. You do all kind of investigation with ultrasound, you can get a CT done. You'll end up with anything. So this was the scenario that we understood as biliary dyskinesia. That's not the only scenario of biliary dyskinesia. It's quite a varied scenario. So, as I said earlier, even in a patient who is not having condition, you could be having a biliary dyskinesia. The fourth could be a gallbladder pathology being diagnosed as a or cholestatus. Right? So this is basically a scenario where we used to diagnose acalculous cholestatus, a chronic acalculous cholestatus. Very often find any stone, and we had a patient who had a typical biliary pain, and we said this is acalculous cholestatus. We used to operate on these patients, and this was usually what we were looking at. And we usually term them status. We never call them biliary dyskinesia. But probably these patients whom we used to diagnose as acalculous cholestatus could well be patients who are having biliary dyskinesia. So basically, this is quite a variable kind of clinical scenario. But fortunately, unfortunately, the functional gallbladder disease is now being diagnosed more often. And that's evident by the number of cholestasis that we perform. Initially, it was let's say about 5%, and now it is almost 20-25% of patients being studied with cholecystectomy for the diagnosis of biliary dyskinesia. So basically, the functional gallbladder disorder, that should be a diagnosis. In all those patients, we have the classical biliary symptom, and if you find anything on an ultrasound or CT scan, and the enzymes were normal, the biochemistry was normal. So this is basically a diagnosis which should now be entertained even preoperatively rather than just sticking to this diagnosis as a post-operative diagnosis in a patient who has a post-cholecystectomy syndrome. So what is the definition? What the definition of biliary dyskinesia? If we look at the definition of biliary dyskinesia, so what constitutes the definition? One is a functional gallbladder disorder, or it could be a functional disorder of the biliary sphincter of Cooper, or it could be a diagnostic SQG, and it has to be substantiated by rigorous investigations using out the more common etiologies where you do find some kind of positive feature on investigation. And the best definition, these are basically contributory definition. The best definition based on the Rome 4 definition of. Now, basically, this is what we are sticking to. This Rome was the Rome 1, Rome 2, Rome 3, and Rome 4. Basically, the meeting had all gastroenterologists and surgeons, gastrosurgeons in Rome. This is the fourth meeting, and they came up with the definition of biliary dyskinesia. And for defining this biliary dyskinesia, according to Rome 4 definition, we had to have a definition of biliary type pain. Now, there's no definition of biliary type pain. You could contribute a number of things to biliary type pain. It could be epigastric pain, it could be right hypochondrial pain. So let's see what the Rome 4 criteria is all about. Now, the Rome 4 criteria for functional gallbladder disorder and the Rome 4 criteria for biliary sphincteropodia disorder. The first one. See, one thing is very common to both of them. So Rome 4 criteria for functional gallbladder disorder. This, I think somebody's mic is on. It's not. I can hear the voices behind. Okay, so the Rome 4 criteria for functional gallbladder disorders, the inclusion, which is a must, is number one, it should be having a patient having biliary pain, and at the same time, the absence of gallstones or other structural. And supportive criteria would include. Could you please switch on? There's too much. So it's basically somewhere else that this static is coming. Somebody's talking behind. Okay, so the supportive criteria has to be low ejection fraction on converse in this graph. And number two, it has to be substantiated by normal liver enzymes and mileage. Now, these are supportive criteria. The two important ones, number one, it should be having biliary pain. And number two, there should be absence of gallstones or any other structural pathology. Now, let's look at the sphincter of Kodai diagnostic criteria according to Rome 4. Number one, that should also be having a biliary pain. So one thing is common to both of them. There has to be biliary pain in both. Here, there's either elevated liver enzymes or dilated bile duct, but not both. I mean, you should have only one of these, either biochemical parameter alteration or finding a dilated bile duct on a ultrasound or CT or whatever you're doing. And number three, absence of bile duct stones or other structural abnormalities, because if that creeps in, it cannot be a functional biliary sphincter of Oddi disorder. It has to be something really a non-functional, right? Here, the supportive criteria has to be should be normal amylase lipase. Abnormal sphincter of Oddi manometry. This could be taken, could not be taken. As we go further, we'll talk about what this manometry is all about, and abnormal hepatobiliary scintigraphy. So this was the Rome criteria, both for gallbladder disorder, functional, and pointed out is the biliary pain is common to both. Now, what is biliary pain? Now, this is again a definition by. So in future, if you ask about what a typical biliary pain is all about, you have to, number one, it is described as all these things are important. Or described as number one, an epigastric or right upper quadrant pain. It should be a steady level and for 3 minutes or more. It should be a different interval. That means not daily, occurring 2 days or 3 days or 4 days. Severe enough to interrupt activity or visit. It should be not significantly related with bowel movements, not significantly related by postural changes or acid suppression. Now, all parts, that is 1, 2, 3, 4, and 5, 6, all parts are essential if you want to define a biliary type pain, right? So it just doesn't gel if you just say I have a pain in the epigastrium, it's radiating my back and to my shoulder, and that's all. No, that is not. That's not. So you have to have all these 6 points to be mentioned when you call it a biliary type pain. Supporting features could be the patient could be having nausea, vomiting, the pain could be radiating to the back, or the pain results in waking up from sleep. So these are thus additional contributory points, but these 6 things have to be there in any biliary type pain. Is that clear? So next time I ask about a biliary type pain, just be sure to say according to the Rome criteria, Rome 4 criteria, these 6 things are important. Is that clear? Right. So what is the pathophysiology of biliary dyskinesia? Now they still don't know the exact pathophysiology, so there were three hypotheses. Number one is probably a bile composition which somehow leads to gallbladder inflammation, chronic cholestasis, associated pain without calculus. Remember, it's without calculus. Okay. Number two, functional problem of the gallbladder or sphincter of Oddi, which represents symptoms of a larger GI disorder like visceral hypersensitivity, as seen in a irritable bowel syndrome. So it is a generalized visceral hypersensitivity, not only gallbladder. Generalized, because remember, the gallbladder is also supplied by the vagus, and the rest of the viscera also being supplied by the vagus with the parasympathetic supply. So it has to be generalized visceral hypersensitivity, or it could be as a result of neurohormonal receptor or neurological abnormality. Like example, the CCK or cholecystokinin, which is the most important positive or contracting hormone for the gallbladder. It leads to contraction of the gallbladder, the most important hormone. There could be either an alteration in its release, or there's something wrong with the receptor on which it attaches itself, or the density of the receptors have been altered, or there's an impaired smooth muscle contractility in cholecystokinin. But the end point, whatever the hypothesis, the end point has to be that there is an altered gallbladder or sphincter of Oddi contraction, which ultimately leads to a back pressure, inflammatory, and biliary. Is that clear? So that is the end point. Whatever the hypothesis, the end point is this. Right. So let's talk about the extra hepatic biliary system and the sphincter of Oddi, because we need to know in short what we basically talking about. What is the sphincter of Oddi? Now remember, these tubes which are coming, the CBD, which is coming out here, is basically just a fibrous tube. It's elastic fibers and fibrous tissue along with a single layer of contact epithelium, columnar epithelium, right? There's no muscle except in the terminal 1 centimeter. And then terminal 1 centimeter, which is partly extradural and partly interdural, right? So part of it is lying inside the duodenal wall, part of it is not. And there could be three main types of junction with the pancreatic. So this is pancreatic duct, the common bile duct, right? So the most common, of course, is the ampullary type, which is there in almost 2/3 of the patient, and the ampulla is almost 1 to 3 centimeters long. We just show in the next slide, excuse me. The 1/3 are probably together, they're having almost joint opening, but the third is 3%, they got absolutely separate opening separately. But here both of them are basically opening at a common opening without an ampulla. So this is ampullary, this is extra ampullary, no ampulla here, and this is absolutely two different, right? Okay, now this is basically what we are looking at. If you look at this is basically the sphincter of Boyden, which is basically the sphincter which is lining the lower part of the CBD. And it's divided into two parts, part 1 and part 2. And look, this whole length of this sphincter complex, I'll call it the sphincter complex. The second is the duct of Wilson, and the third is basically ampullary sphincter. Part 1, part 2 is basically the voided, right? So these are basically the sphincters which are lining. Now, what's the clinical importance of these sphincters? This is basically the sphincter we talked about. This is about 1 centimeter, this 0.6 centimeter, and this is roughly about a centimeter. So total, they make up 30 millimeters or 3 centimeters of this sphincter complex, right? Now, the clinical importance, what is the clinical importance? Number one, proximal occlusive zone. So this is basically occluding the CBD, occluding the pancreatic. Middle infundular segment, which can be easily dilated. So you can easily dilate the middle segment. And this is the most distal or the inferior part which participates in the formation of the ampulla. And this is basically what we do, or the gastroendoscopist, when he says that he is given a slit on the sphincter or sphincterotomy, he's basically cutting through this. He's cutting through this. He's not cutting through all, he's just cutting through this. So that is basically the terminal part of the sphincter we're talking about, right? So let's talk about the innervation, because we are basically talking about what? We're talking about some kind of a deficiency in the contraction or relaxation of these muscles. So the parasympathetic supply to the gallbladder is basically the hepatic branch from the anterior vagal. I think we talked about that in the last lecture. We were talking about the gallbladder and the treatment of peptic ulcer disease. We said that the anterior vagus gives the hepatic branch. So that is basically parasympathetic. It leads to contraction of the gallbladder and relaxation of the sphincter of Oddi. At the same time, the sympathetic supply, which is coming from T factor T9 through the great flank neck, which goes to the celiac, and from the celiac, you have the fibers coming to the gallbladder and anastomosing out there, right? And then, of course, the sensory fibers to the gallbladder are possibly some fiber intercrossing from the right phrenic, that is the root value of somewhere beneath C3 or C5, right? So these root value fibers, we'll just explain how they come. Some of these fibers are short-circuiting in the celiac ganglion. Why the short circuit occurs, nobody knows, but these fibers are short circuiting out there because C2 to C5 has got there's no reason why it should be coming to the celiac ganglion. That's basically the cervical part, right? So it should be coming to the celiac ganglion, which is purely a abdominal ganglion. But there is some reason why it happens. Now, the gallbladder fills and empties cyclically by the duodenal myoelectrical complexes, number one. Number two, the gallbladder distension is probably related to the sphincter foci tone via the cholecystosphincteric complex. Now, this basically complex nothing, that the sphincter gets the impulsion that I have to relax because the gallbladder is already full, the CBD is not dilating itself, so I have to relax. And that usually occurs in the postprandial period. So that reflex sets up, and the sphincter foci releases the part of the bile stored in the gallbladder and the CBD. Okay, so that is the cholecystosphincteric complex. Why cholecysto? The reflexes sets up from the gallbladder. That's why cholecysto. Probably I missed an N in the sphincteric complex. Just add an N to it, right? The visceral organs, they share the same sensory innervation. I was just telling you that the same vagus is supplying the whole of the small bowel, the large bowel, the colon, and the stomach, and everything, right? So that is basically a generalized visceral supply by the vagus, and that's what we are saying in the second hypothesis, that probably there's some kind of a visceral abnormality or hypersensitivity responsible for the whole gamut of syndrome, right? The hormonal regulation is again very, very important. Why? Because the two hormones, the cholecystokinin and secretin, and among these two, the cholecystokinin pancreozymin is perhaps the most important. Now, secretin basically released from the S cells in the proximal jejunum. All these are being released where? The proximal jejunum and the duodenum. Secretin from the proximal jejunum released by stimulation by what? Partially digested protein and acidification duodenum. So the stomach has released part of the digested food into the duodenum. Immediately what happens? There's a reflex set up and the secretin gets secreted from the S cells of the proximal jejunum, and they then go and do what? They increase the production of bile and pancreatic secretion, and the main action is probably on the ductal system rather than on the gallbladder. And the main action is secretory. But cholecystokinin is now getting secreted from the eye cells of the proximal small bowel, the duodenum, and the neurons of the distal ileum, colon, and brain. So this has got a wider spectrum from where it is being produced. Now, what do they do? It's got basically a stimulatory and inhibitory action. Now, what are we concerned with? We are basically concerned with the most important stimulatory, that's contraction and emptying of the gallbladder. At the same relaxation of the sphincter of foci. So two things are happening. When there's contraction and emptying of the gallbladder, it's also relaxing the sphincter of foci. So it's basically ensuring what? It is ensuring that whatever is being released from the gallbladder and the CBD is now getting into the duodenum. That's the whole action of cholecystokinin. The other ancillary actions, basically the increase in the pancreatic enzyme, the increased hepatic bile, increase in intestinal peristalsis, increase in intestinal blood flow, they all geared about what? They all geared towards one end. And that end is trying to propagate the assimilation of the foodstuff into your circulation. It inhibits the gastric outflow by contracting the pyloric sphincter. So it tells the stomach, look, don't release at one go, partial release. So it is inhibiting the gastric outflow until it is helping in the digestion of what is lying in the duodenum and the jejunum. Until that time, it stops the gastric outflow. It suppresses the appetite because it says, look, I have got enough, so don't eat more. So suppresses the appetite. And at the same time, decreases systolic blood pressure. Okay. Now, the gallbladder and CBD pressure relationship is also very important. In a nutshell, if you don't want to remember these pressures, in a nutshell, just remember two or three things. Number one, that among the four, the common bile duct, the pancreatic duct, the sphincter foci, and duodenum, the the least pressure zone is the duodenum. See, 5 to 6 centimeters of water. Now, this is the mercury, millimeter of mercury. This is basically water. So the least pressure is in the duodenum. The maximum pressure is the sphincter foci. The next comes in ascending order is the CBD and the pancreas. So basically, the pancreatic duct and the sphincter foci have got almost same. See, pancreatic duct and sphincter foci, 22.2 centimeters, 15, 20 centimeters, almost the same. But CBD has got slightly less, and the least is duodenum. And that is why one of the common problems in any sphincter of Oddi disorder is that you can easily have a pancreatico-biliary reflux. That is very easily explainable, right? Why? Because the pancreatic pressure is always more than the CBD pressure. Point number one. And together, the pancreatic and biliary pressures are less than sphincter of Oddi unless it chooses to relax. And because the pressure in the duodenum is the least, so the outflow is very easily enabled if the sphincter of Oddi relaxes. There's no problem. Because from high pressure to low pressure, no problem. The only condition being that the sphincter should relax. So basically what we're talking about in the gallbladder and CBD relationship is that both the CBD and pancreas can easily empty into the duodenum once the sphincter of Oddi relaxes. There has to be a coordination between the contraction of gallbladder and relaxation of the sphincter of Oddi, which if it doesn't occur, then you have these biliary dyskinesia problems. That is one of the main things. So if you don't want to look at the whole slide, this was the gist of the slide, that these are the pressure differences, right? Now, when the gallbladder tries to empty in the resting state, does it empty? Because I have not had anything to eat for a long period of time, let's say 2 or 3 hours fasting. Now, what is happening to the bile in the gallbladder? Is it absolutely zero into the duodenum? No. A part of it is trickling down based on what? Directed by the duodenal intestinal housekeeper. Remember, we talked about 2 housekeepers, one in the stomach and one in the duodenum. Those pacemaker peristaltic activities, very slow, 3 to 4 and 4 to 6, they basically enable whatever is lying inside the intestine at that point of time in the fasting state is propelled onto the distal part of the bowel. So here also, what is happening is that there is partial relaxation of the sphincter of Oddi and contraction at the level of the sphincter of CBD. Remember, the rest of the CBD doesn't have any muscle, so it cannot contract. So contraction of the gallbladder and the release of bile from the CBD into the duodenum. So there is a continuous bile flow because rhythmic contraction at the rate of 2 to 6 per minute. This, if you remember from our lecture on the stomach, where we said that duodenal housekeeper released 2 to 6 times per minute, and basically the gastric housekeeper is somewhere in the region of 2 to 3 times, right? Now in the postprandial period, I have had something to eat. Now what happens? Immediately the vagal impulses start, the hormonal secretion starts. So the vagus now contract in the gallbladder, and the normal ejection fraction, don't forget this, the gallbladder should contract to about 60% of its volume if it is functioning normally. Is that clear? 60%, don't forget this figure. Because just having an ultrasound diagnosis of a deficient gallbladder based for dyskinesia is not enough. It's not enough. You should have a demonstrable release of bile, and the gallbladder should decrease in volume by 60% before you can say that my gallbladder is functioning normally. So 2/3 of its capacity, or more than 60% ejection fraction from the gallbladder, just like ejection fraction of the heart. What is normal? Somewhere in the region between 5 to 60%. Similarly, the gallbladder 60% ejection fraction should be there within 30 minutes of having something to eat. Remember, it's 30 minutes. So that means if at all you want to diagnose a biliary dyskinesia based on ultrasound, have a meal and get an ultrasound before 30 minutes and after 30 minutes. And if you can demonstrate that there has been a reduction in volume of 60%, your gallbladder is absolutely normal. If there is no stone in it, of course. So we here is basically talking about no demonstrable physical or any kind of other abnormality inside the gallbladder. We are trying to diagnose a dyskinesia, right? Now, number 1, vagal stimulus, and number 2, cholecystokinin, which acts by itself. Number 2, and it also potentiates the action of vagus. The action would be inhibited by what? By the amount of bile acids and proteases in the what? In the jejunum. So when it has had enough, it will say no more cholecystokinin, no more vagal impulses, stop contracting. And the gallbladder starts inhibiting its contraction. What are the inhibitors? Number 1, prolonged fasting as in DPN, but at that point of time in the postprandial period, the somatostatin, the vasoactive inhibitory peptide, the polypeptide, and polypeptide YY. So these are basically all the hormones and cytokines which are trying to stop the gallbladder from contracting. So these are inhibitors of emptying. Now, when you had a vagotomy, remember we talked about truncal vagotomy last time, and we said if you cut the trunk of the vagus, you're also cutting the hepatic branch. Now, what happens when you cut the hepatic branch? Is the gallbladder not contracting? No, it becomes a flabby gallbladder. It enlarges in size. But remember one thing, the emptying is perfectly normal. Is that clear? So even when you have a vagotomy done, the emptying of the gallbladder is not affected, but because the gallbladder size is increased, so the stasis of bile would be for a longer period of time. That's why increased incidence of gallbladder stones in post-vagotomy. So this is basically just depicting the cholecystokinin secretory actions. See, this is basically a duodenum, increase acid, protein and fat ingestion. As soon as it's being released into the duodenum, what happens? Secretin release and CC get released, both from the S cells and I cells. This has an effect probably only on the liver, increasing bile secretion. So increased bile secretion. And here what is happening? What happening? Gallbladder and sphincter foci, contrast effects. This contracts, this relaxes. As simple as that. So the duodenum ultimately lands up with what? Increased amount of bile coming into its fold. Okay. So if you look at the pathological changes, so we now know what is basically happening. Now, what are the pathological changes in patient with biliary dyskinesia? 86% of patients with pre-op diagnosis. Now, remember, we are forgetting only the post-operative syndrome, where we used to diagnose biliary dyskinesia with a patient with persistent pain. We never knew about this part that pre-operatively can diagnose biliary dyskinesia. Most of these acalculous cholecystitis are nothing but biliary dyskinesia. So, what happens in these pre-op patients who have got a gallbladder intact? Now, excuse me, 86% of these patients with pre-op diagnosis of biliary dyskinesia would probably show some kind of a chronic inflammation, some degree of inflammation. That will be there. But there should be no evidence, there has to be no evidence of sludge, stones, stump stones, a remnant of the gallbladder stones. No, nothing should be present in either pre-op or the post-op. And the ejection fraction of a patient with biliary dyskinesia should be somewhere in the region of less than 35 to 40%. This is a landmark, or this is a cutoff point for diagnosing biliary dyskinesia. But because it's a changing and variable parameter, that's why it's not a very good parameter. But even if you demonstrate the ejection fraction to be less than 35% one time, then that raises the suspicion of having biliary dyskinesia. So remember, normal ejection fraction 60%, a defective ejection fraction in the region of 35 to 40%. Is that clear? So one thing else we need to know, and that is that biliary dyskinesia could be associated with number of other diseases. And these are basically stomach disease or upper GI, like example GERD, gastroparesis, IBS, chronic constipation, chronic inertia, the coronary problem. Then you can have liver problems, like example end-stage hepatic disease, or steatohepatitis, or you can have a morbid obesity, rapid weight loss, both contrasting, but both can give rise to biliary dyskinesia, or diabetes mellitus. So biliary dyskinesia is not necessary to have this as an isolated problem. It could be a problem which is associated with a number of other diseases, right? Now, what are the signs and symptoms in an unoperated patient? That means gallbladder intact, pre-operative. What could be signs and symptoms? Symptoms mimicking gallbladder pain. We just not defined what a gallbladder pain is. The right hypochondrial pain. No GI symptoms apart from the gallbladder pain. We just now said that. Pain resolves within 6 hours. Part of the biliary deflation. Resolution is 60%. This is different. So this is something additional. So in a patient of biliary dyskinesia, there should be resolution in 60% of these patients over a period of time. Now, what is that period of time? That basically is somewhere in the region of months or years, right? And can be associated with recurrent pancreatitis. See, this is one additional thing, that it can be associated with recurrent pancreatitis, especially which type? Especially the sphincter of Oddi dysfunction type. We just now said two types. Number one, biliary dyskinesia gallbladder type, biliary dyskinesia sphincter Oddi type. So those who have got a sphincter Oddi type, they could be having recurrent pancreatitis. In a post-operative patient, which we are more familiar with, a patient coming to us after surgery or after lap polio, standard cholecystectomy, keeps coming back to us. That is the patient we always knew could be having biliary dyskinesia. We never knew a preoperative patient would be having biliary dyskinesia. So this was the more common patient. The post-operative patient, a persistence of the right hypochondrial pain, epigastric pain, upper fullness, GRD, and other the vague upper abdominal symptoms. They are not able to explain. So basically, they are very vague, non-specific symptoms. And signs are very important. And what is the most important sign of biliary dyskinesia? No sign of tenderness, no sign of guarding, no lump present. That is very, very important. The moment you have a lump in the abdomen of a gallbladder lump, be sure it's not dyskinesia. Or you have guarding there, if you have tenderness there, this cannot be biliary dyskinesia. So no sign of tenderness, sign of gallbladder lump, no sign of guarding. That is very, very important. Now, what could be the differential diagnosis? We have just said that we have got this typical biliary pain, but a right right hypochondrial pain could be because of number of other things. You all know that. Just to repeat it, number one, you could be having a cardiac disease. You could have acute pleuritic on the right side. You could have a neuropathic or myogenic pain. Absolutely not concerned with anything inside the abdomen. They are thoracic problem. Or you could be having a hepatic problem, acute hepatitis, patient with hepatic abscess. So many patients with abscess, we always knew that they are coming with hypochondrial pain with pain reflected to the right. We all know that. Then peptic ulcer disease, GRD, renal causes, right side pyelonephritis could be presenting with the pain in the right hypochondria. A patient who has got a retrocecal or subhepatic appendix, a high appendix, they could be presenting with the same symptom. Irritable bowel disease, right colonic diverticulitis, etc. and etc. All those causes which could possibly give rise to pain in the right hypochondrium, they have to be excluded before you can say that my patient has got biliary dyskinesia, right? So how do you make a diagnosis? Remove or you have to decide that no other cause could be responsible. And whatever you may use ultrasound, you can use a CT scan, you can use an MRI, you can use endoscopic ultrasound, whatever is required. You can do an OGD, but you have to demonstrate that there is no pathological lesion giving rise to this kind of a pain in the eye. Only then, and then you can be sure that you're probably dealing with a biliary dyskinesia. And then what do? You do a cholecystokinase cholecystography. And how do you do that? Number one, 4 hours fasting. Stop all drugs which are acting on these foci. Usually, morphine and like drugs, like pentazocine, nitrites, calcium channel blockers. None of these drugs should be there when you're doing this investigation. What do you do after 4 hours of fasting? Administer this patient with technetium labeled, right? Then CCK infusion over 20-30 minutes. Now, CCK can be given either as a 2 to 3 minutes infusion or 20-30 minutes infusion. 2 to 3 minutes infusion is probably not as good. Why? It sets up a lot of abdominal cramps and the patient is so discomforted that now everybody accepts that this should be administered as a 20-30 minutes infusion. And then what are you demonstrating? You're demonstrating a less than 35 to 40% ejection fraction after about 20-30 minutes of infusion. And if that is there, that is good. See, variability results ultimately leads to what? Not a very good confirmatory test, only contributed. See, this is in bold. You can't confirm that you have got biliary dyskinesia based only on a cholecystography, but it is only contributing. That's why we say no criteria. Remember, you know what? Contributory symptoms. Absolute was just one biliary pain, and number two was demonstrating that there's no other pathology in the gallbladder. So, hallmark of biliary dyskinesia, as said earlier, is a low gallbladder ejection fraction. Now, now, instead of this, now what is being used is MRI, EOS scan. Here, what you're using is a gadoxetic acid, which is 50% excreted by the biliary system, and that is basically now the preferred rather than the HIDA. This is the preferred method. Radioactive gadoxetic acid is preferred method, along with the contrast MRI is a preferred method, cholecystoscintigraphy. Right? That is the preferred method to get. Now, the other thing you would like to do when you're suspecting a SO or a sphincter foci, you can do a manometry, right? And it's usually is only in that group of patients that we knew that the post-operative patient. This can never be done in a patient with an intact gallbladder. It should never be done. It doesn't give a good result. It can only be done in a patient where the gallbladder has been removed and the patient is coming with a dyskinesia, which is probably mediated by the sphincter foci. Only then do a post-cholecystectomy sphincter foci manometry. Right? And with this, at the same time, imaging the biliary duct, imaging the pancreatic duct, and doing a pressure manometry of the sphincter foci. Now, normal pressure of sphincter foci should always be less than 30 millimeters of mercury or 40 centimeters of water, always. If you have anything more than 40 millimeters, that tells you probably this patient has got a dysfunction of sphincter foci. Right? 40 milliliters of mercury or 55 centimeters of water. That is almost confirmatory of a problem with the sphincter foci. But there's so many variables. The measurement is very difficult technically, and there's so many variables that you can never have an exact value of the pressure of the sphincter foci. And that's why it should only be done at specialized centers who are well versed in doing this sphincter manometry. It's not a one-time. You decide, look, I'll do this manometry today, and I come up with a result and say, yes, this patient has this. No, absolutely not. Unless you've got a specialized center who have done a lot of manometries for sphincter foci, you cannot confirm that your result is absolute. And at the same time, what else is problematic? The number of side effects of perforation, acute pancreatitis, delayed papillary stenosis when you're doing the manometry or after the manometry. That is why this would be. The endpoint of treatment is simple, and that is a successful treatment of biliary dyskinesia means what? It means absence of biliary pain for 12 months post-op. If you have opted on a patient with biliary dyskinesia, or you're treating a patient with biliary dyskinesia, you would say that my treatment is successful if the patient doesn't come back to you within 12 months with any further pain. So that is the end point of therapy. Methods, number one, conservative, no specific study done date. No specific study. Spontaneous resolution occurs by itself in 60% patient, don't require any treatment. But you may hope to give calcium channel blockers, but the problem with calcium channel blockers is the increased amount of side effect of headache and tachycardia. So basically, most of them would not be, or these drugs would not be advisable. And even otherwise, none of the conservative therapies have been or level 1 evidence presented that look, this could be done in this patient because 60% spontaneous residual by themselves. Then what about lap chole or standard chole? Yes, when the gallbladder is present, this could be the standard of treatment, and a Cochrane review with 2 to 3 meta-analysis and 10 studies has shown 95 to 98% benefit. 20% of patients still have continued biliary pain, right? Some kind. But the benefit in 95 to 98%, it's a benefit. It is not a complete cure, right? Because of the cholecystopapillary reflex, what is one problem? That problem is that this cholecystectomy actually aggravating your problem. And that is why this exacerbation of the functional SO disorder advise the patient of the possibility of an exactly opposite outcome after cholecystectomy. That this patient becomes more problematic because if he has only sphincter foci, doing after what is the doing? It was basically a storehouse. So now that reservoir function is gone. So everything is now lying over the CBD and the sphincter is not functioning normally. So it's an actually exacerbation of the symptom. So remember, before advising a patient cholecystectomy for dyskinesia, you have to alert the patient of the possibility of getting exactly opposite results. While in a post-cholecystectomy patient, you have done a chole and patient comes back to you with what you ultimately diagnose with dyskinesia. What can you do for this patient? You can do a sphincterotomy, ERCP sphincterotomy. Or you can inject botulinum toxin into the sphincter foci, tried experimentally, but no specific evidence today. Both have a debatable result. Even a sphincterotomy has a debatable result. So can you see a basically special group of patients? Pediatric. Gradual increased number of cholecystectomies in children with diagnosis of dyskinesia. And the ejection fraction 35 to 50% has been taken as the cutoff point. Resolution of symptoms has been seen anywhere from 34 to 100%. So that is a very varied effect. That means the patient comes to you say, look, you're doing a cholecystectomy in me. You advise cholecystectomy, would I be absolutely cured? You cannot say that. This patient can be cured only 34% of time, or he can be cured 100% of time. So there are no controlled studies as yet. So this is again a gray area. What is a hyperkinetic gallbladder? And hyperkinetic gallbladder is a gallbladder which shows an ejection fraction of somewhere in the region of 80-85%. And what's the significance? We don't know. We don't know the significance. What is the significance of gallbladder showing an ejection fraction of almost 85%? We still don't know. There is a pediatric group of patients who has CS of more than 85%, and they have shown feature of chronic cholestasis, inflammation. That patient could be pain-free at 30 to 45 months, almost 30 to 45 months, if the patient has got evidence of chronic inflammation. And similar to a patient with cholecystography who shows a defect in the cholecystography, in adults, there is a 90% response. So what is the flow chart? Come to the last slide. The clinical history of biliary pain. Patient comes to you with biliary pain, episodic, right upper quadrant. This was according to the definition. Okay, the definition of biliary pain, he confirms to the definition. Now what do? The initial study of ultrasound and liver function test. What do you land up with? Abnormal. That is very clear. This patient does not have dyskinesia. He's got structural problems. He's got intraluminal problems, so on and so forth. But a patient who has got a normal ultrasound or normal liver function, now you send this patient to a endoscopic ultrasound. Abnormality, shove this patient into this group, no longer conforms to dyskinesia. But you have a patient who still shows normal finding. Now this is a patient who has now got a high suspicion of having dyskinesia. Now what do? Now you do the scintigraphy or MR with. Now what do you do? Abnormal or normal? Both these. If a function is less than 40% or he's got normal. Both could be basically a functional disorder. If he's got less 40%, then he's probably got a gallbladder disorder. If he's got the ejection fraction normal but still showing signs, he's probably got a functional sphincter odi disorder. Very, very clear. Very, very clear, right? So ultimately land up with what? With an ejection fraction of less than 40% or normal ejection fraction. If normal, having all these positive, all these conforming to all these, and normal EUS, normal ultrasound, etc., 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 he has got a sphincter odi problem. If he has got a less than 40% sphincter scintigraphy ejection, he's got a functional gallbladder disorder. Is that clear? Now, this is basically the Rome 4 criteria of diagnosing biliary dyskinesia, and this is the best I could find biliary dyskinesia. And there were some new things which even I didn't know. So, this is basically, I think, the best method of diagnosing biliary dyskinesia, best method of deciding what a biliary pain is all about, right? So, this was about the biliary dyskinesia. And I said earlier, you can all go and visit the past lectures on my website and YouTube Prime. But don't go away. Don't go away. And we are going to talk about something which.
This conference will now be recorded.
Okay, now, so we'll be talking about the gallbladder.
This conference will now be recorded.
You just continue with this. So let's go about gallbladder. Go away. There are a number of things being helpful. Okay. Clear now? You can hear me? Hello?
Yes, sir. Yes,
So
sir.
we
Yes,
talk
sir.
about anatomy, physiology. I think a number of them points should be useful to you for the PG. Of course, for the UG, it's there. So we're just talking about the anatomy gallbladder, which is represent crouch watching of the extrahepatic system. I don't think we need to go into the development. It develops on the hepatic part. We all know that. But ultimately, when it develops, it's a pear-shaped organ about 10 cm long, 3 to 5 cm diameter, capacity 30-60. A Hartmann's pouch is the first question mark which comes in, where the Hartmann's pouch is a normal gallbladder structure or it's an abnormal. There are anatomists who would say this is not a normal part, it's an outpouching because of a stone at the neck and gradually develops when the stone is there in the neck. So it's not a component, a normal component of the anatomy of the gallbladder. Whichever you want, you can stick to it. Now there are two things. Number one, that there are mucosal folds at the neck and the cystic duct, and these they help in keeping the patency of the cystic duct. Now, maintain the patency of cystic duct is basically the domain of walls of Heaster, and there is a sphincter-like muscle out there, and that is known as the sphincter of Lutke's, which control the bile flow from the gallbladder into the CVD. Right now, the form and position varies with the body build of the patient, and if you got a broad body build, hyperesthetic, now the gallbladder is higher, lies high up and far laterally. Now, why do you need to know this? This basically in deciding, especially in today's world where you're doing a laparoscopic cholecystectomy, it basically helps you decide where you have to put in your port within the mid-clavicular and the anti-axillary if you're using the anti-axillary port also. The inner surface of the gallbladder covers small polygonal compartments opening onto the interior, and that basically resembles a comb-like villi, honeycomb-like villi, which are basically helping the absorption. Now, here comes the first problem or the first change in the anatomy. And the anatomy changes that there is no submucosa in the gallbladder. It starts from inside out, the single layer of columnar cells, the tunica propria. But there is no submucosa out here. Straight away, it jumps onto where the muscular core and the subserosal layer and the serosal core. And the second difference from the normal anatomy is that there is no serosal coat, it's absent where the gallbladder is applied to the liver. So two differences from the normal wall of the GI. Number one, there is no submucosal layer, and number two, the serosal coat is absent where the gallbladder is applied to the liver. And then comes the understanding of what is known as the cystic plate. Now, we didn't know the cystic plate, but now we know it when we are doing a laparoscopic cholecystectomy. When we lift the gallbladder up from the liver, we find that there is a bed of the gallbladder, and often you find that there is basically a whitish layer in this area, and that is what we know as the cystic plate. Now, just for information, the gallbladder has got three plates to it, which are nothing but condensations. These are condensation of the connective tissue from the Glissen's capsule, which covers the liver. And these are condensations, and the condensation we are talking about is the cystic plate. See the CP as a cystic plate, and then you got the hilar plate, right? So these two are important. Why? Because these two are in contact with each other, as opposed to the umbilical plate, which is only continuous with the hilar plate. Now, so this is basically a plate out here, connective tissue lining the inner surface of segment 4 and segment 5 out here, and separates the gallbladder from the liver. Now, what is important is that where these two join together, this is basically, you see, it narrows down and continues the hilar plate and gets attached to the sheath of the right portal vein. Right portal vein is out here. The portal vein divided into the right and left side, so it gets attached out here. Now, when it's getting attached out here, what is lying in between? You basically find the right hepatic artery in between, and you got the portal vein behind, continues out here, and anteriorly the right hepatic artery. So that is why this forms a demarcation point between the cystic plate and the hilar plate. And what is about the cystic plate? It separates, and there is no serosa in this area of cystic plate. Point number one. Point number two, in the area of cystic plate, there are a number of small biliary canaliculi which could be communicating from inside the liver to the gallbladder. Point number one. Number two, just on the cystic plate, you have got a major tributary of the right hepatic. Right hepatic is coming out here. So right hepatic vein, a major tributary. So if you go deep in and lead to torrent. If you go deep inside, what's going to happen? You're going to damage the right hepatic vein, torrential troublesome bleeding. Hepatic vein is lying of communications, both venous from the gallbladder into the liver and a number of biliary canals. So you can have both. So you got three problems here. Three problems. Number one, underlying right middle hepatic vein. Number two, you've got communication, biliary communication. And number three, you've got small venous communication between the gallbladder, venous outflow, and the hepatic. Is that clear? Now, all the lymphatic glycerin sheath goes through this plate system. One more thing, and that is that the lymphatics are communicating with each other from the gallbladder with the lymphatics under the glycerin capsule. So now you got four problems. Problem number one, canaliculi communicating. Number two, veins communicating. Number three, lymph nodes, lymphatics communicating. And number four is the right middle hepatic vein just underneath the cystic plate. Is that clear? Now, congenitally, there could be a number of problems with the gallbladder. Among them, you could be having the double gallbladder. You could be having the septate gallbladder, the Phrygian cap. There's a Phrygian cap. And the name, as you know, you could read even from Love and Bailey, that Phrygia was basically a country from where they used to wear this cap. Medieval time, there was a country, and their cap was shaped like this. That's why the name Phrygian cap, right? Number two, there could be two cystic ducts, or you can have a floating gallbladder. It's got a lot of mesentery to it, keeps on floating. Not a very common occurrence, but it does happen. Or you can have a segment 6 duct opening into the gallbladder, right? That could be a problem. See, opening here. So when you're ligating, you ligate out here, and suddenly you find that the bile leaking out, and you don't know what's going to happen. So instead of ligating out here, you should be ligating here. And that creates a problem of one of the abnormalities in the post-cholecystectomy phase, right? Or if you're having a duct, right posterior sectorial duct going through the liver, going through the gallbladder. So here again, if you dissect out cystic duct and cut out here, and then what do you find? You find another duct coming out, you cut out here. So what are you doing? You're cutting the right posterior sectorial duct. So remember, in these cases, it should be only here. That's why you need to know these some of the abnormalities, especially the segment 6. These are very important for if the and then you will on the form jaundice, and right, the arterial supply is simple. The cystic artery is the right hepatic artery. It divides into two: the superficial or the anterior branch and the deep branch of the posterior. Runs in between the gall. Now the variation in ductal and arterial supply as many as one-third patient. That is important. That means out of 100 patients being operated for gallbladder, you find 33% will not be showing a normal error. There is nothing normal, abnormal in therapy concerned with the gallbladder ductal system or with the arterial system. So one third. What are the differential? Okay. Number one, double cystic artery. And often when you're doing this, what do you find? Ligate one, and in the section of the callous triangle, you find one more, and that is the second cystic artery. So coming both from the right hepatic artery, that shouldn't be a problem. But then you have to ligate one then, because if you just ligate these two and you're happy, and then you start dissecting out, you find a spurter. Now what's that? You missed the second cystic artery. So remember, there could be double cystic artery. There could be an aberrant origin of the hepatic artery. So instead of hepatic artery coming like this, the hepatic artery could be coming like this, or the hepatic artery could be coming like this. So this is an aberrant hepatic artery dissecting here. What do? You basically ligate here. And what has happened? You have ligated the right hepatic artery. So remember that these hepatic arteries usually show what is known as a caterpillar hump or Moynihan's hump. So Moynihan's hump is very, very specific. It is a normal course of the right hepatic artery, not the common hepatic artery. Is that clear? Would you remember that? So the right hepatic artery has got an abnormal course, that is the Moynihan hump. Okay? The left hepatic artery originator from where the cystic artery is coming. So normally it should come from the right hepatic. It may be coming from here also, the left hepatic. I'll show you the figure in 1 or 2 slides. So three types that we commonly know. This is Moynihan's hump. See, this is the hump. This is the hump. The right hepatic artery, a very short cystic artery. This is the callous triangle, and you find the course of the right hepatic artery. And you say, what do? You dissect out here, you cut out here, and you cut the right hepatic artery. Now what happens? When you dissect, now you have a spurter from here. So you have to cut this also. So you're basically looking at abnormal Moynihan's caterpillar hump due to abnormal cystic artery, abnormal right hepatic artery. Now this is basically the two branches we talked about, the anterior branch and the posterior branch. These two branches of cystic artery, normal branches, anterior and posterior, both on the liver surface. Then you could be having recurrent cystic artery, or you could be having a cystic artery with a low line coming from the gastroduodenal. See this gastroduodenal, or it could be coming from the supramesenteric artery, coming from here, supramesenteric artery. So these could all be the abnormalities shown out here. See this. Basically, normally cystic artery comes behind the common hepatic duct. This common hepatic duct, where it is coming from? Anterior to it. Normally, it should be going posterior to it. This is an abnormal position. There is a callous triangle. What do you find? You find the hepatic artery inside the callous triangle. See this thing. And if you decide to ligate out here, you are in for trouble. What is happening out here? You're ligating the hepatic artery so that the right part of the liver is now suffering from the ischemia. Okay? Here what's happening? Double cystic artery. See the double cystic artery? So these are basically abnormality. Very well depicted out here. So basically what's happening? The common, the right hepatic artery. You could be having it from the left hepatic artery, coming from the gastroduodenal artery, the supramesenteric, the right hepatic, but looping in front, Here, right hepatic artery, cystic artery is not lying in the callous triangle. This is the callous triangle. It's not lying out here. It's outside the callous triangle. Here you got the right hepatic artery inside the callous triangle, and you got the double cystic artery, right? So what is the callous triangle? Now, callous triangle is again an area which was misdefined. I would say the original definition no longer holds true. Now, this was a definition way back in 1891, and it was only this which was defined as the callous triangle. The triangle between what? The cystic duct, the cystic artery, and the common hepatic duct. So the cystic artery is not a constituent. It was not a content of the callous triangle. So the original callous triangle is basically what? The cystic artery, the cystic duct, and the common hepatic duct. This was the original callous triangle. But the new callous triangle has shifted the boundary to the lower surface or the lower margin of the liver. You got the medial surface of the gallbladder, the cystic duct, and you got the common hepatic duct and the right hepatic duct. This is basically the new callous triangle. And based on this definition, the contents, we all know cystic artery, cystic vein. We all know that. Then you got the lymph node of Lund, also known as Mascagni's, This is basically the lymph node. But it may also contain the right hepatic artery. See, it's containing the right hepatic artery. This is the right hepatic callus triangle with the caterpillar hump. It could be having an accessory right hepatic artery, or it could also be having an anomalous right sectorial bypass. And that is why just going ahead and doing a dissection out here is fraught with danger. You could having, I said 33%. So you'll be cutting any one of these. So what should you do? This arrow shows that the dissection should always start from lateral. Define the cystic duct. Define the boundary of the cystic duct. See the cystic duct, and only then go carefully define the other boundary cystic duct. Once you've done that, then go more medially. It should not be coming from here to here. You will not be able to recognize any of these, and you'll be doing what? You'll be cutting one of these important structures, right? This is a good figure of callus triangle and a good figure of cystic artery, the two branches, the posterior and the anterior. And this is, see this? This was the original callus triangle, 1891. The cystic artery, the cystic duct. But now it has shifted up. So now this forms the triangle. The lower edge of the liver, the medial edge of the gallbladder, the cystic duct, and the common. That is the new callus. Now, what are the venous drainage? We know the arterial drainage. Venous drainage we didn't know too much. So what are these veins? Most commonly, these veins are veins which go directly through the cystic plate and open into the hepatic. Which hepatic vein? The right middle hepatic. But there are a number of instances where you would be having a definite cystic vein or two cystic veins which go directly to open into the right portal vein. Right portal vein, right? So this is the most common. This is again a common where it goes into the right portal, right? Okay. Now the lymphatics, we already said the submucosal and subserosal. That means submucosal just underneath the mucosa, submucosal and the subserosal communicate with the subcapsular. That's one. And then details we talked about when talking about the calcium of the gallbladder. Remember this figure? The lymph node of blood. Then you got the cystic lymph nodes. This is basically what? There are local lymph nodes. Not the paradoxal or the peridocal lymph node. Then it comes where? The retroperitoneal. And from here it goes to the pancreas. That is the posterior pancreas. From here it goes to the lymph node which is lying out here. Which one? The superior mesenteric lymph node and para-aortic or intra-aortic. From here, it also goes to one other which is not been depicted out here, and that is the lymph node lying out here, and that is basically which one? The cilia group of lymph node. So that is the complete lymphatic basin, which is very, very important when we talk about the calcium of the gallbladder. You can refer to one of our earlier lectures on YouTube, and you can see this whole thing explained better out there. So just remember the submucosal and subserosal direct communication with the subcapsular. Second, cystic node from here hilar or peridocal. From the peridocal comes to the retroportal, posterior pancreaticoduodenal, interaortocaval, and from here itself, from the peridocal, it goes to the cilia group of lymph nodes. So just remember this lymph node spread, which is very, very important. The nerve supply, you got the parasympathetic motor, we just talked about that, to the gallbladder, the preganglionic sympathetic fibers from T5, T9, and the celiac ganglion, postganglionic fibers, which is the gallbladder. Right? The sensory fiber, just not told you the short circuiting. The one important thing is, why should a patient of gallbladder pathology have pain in the right shoulder? In acute cholecystitis, explainable. Why? The inflamed gallbladder pushes against the parietal peritoneum. The parietal peritoneum has got the supply, the diaphragmatic area has got a supply from the phrenic nerve. So it irritates the parietal. Without
The audio is not visible.
Can you hear me? Hello?
Yes, sir. Now, okay.
Okay. So the bile salts metabolism in the liver, basically in the liver, I'll just tell you in short, there are two primary bile salts. We have
Sir, we are not getting the audio.
now can you hear? Hello? Hello?
Yes, sir. Yes, sir. Audio.
Right? Combined with sodium potassium. So this is basically what is happening in the liver level. Liver level, you got the primary bile salt. At that time, a small amount goes into the sent back to the liver. That is one method of hepatic circulation. And the third most important is what is known as the enterohepatic circulation. So remember, whenever we talk about the circulation of the bile pool, or the bile acid and salt pool, basically it's not only the enterohepatic circulation we're talking about. We know about that circulation. But what else is working is a cholangiohepatic circulation and a pure circulatory circulation coming from the spillover, the systemic, and goes back to the liver.
Sorry to interrupt, sir. Guy named Kota Aditya Raj 57. He has put his mic on, so we are not getting the audio. Aditya Raj 57. Kindly put your mic on.
Hello, can you hear me? Hello.
Yes, sir.
Now
Now
can
we are getting this.
okay,
Yes.
okay. Sorry for that. I think there's something wrong with the mic out here. So basically conjugation to the glucuronide, sulfate, another soluble form 10%, and now the soluble conjugated bilirubin that is goes into the intestine. What I was showing you, right? So stage 1 is basically breakdown, conjugation, uptake by the liver, in the liver conjugation. Then it goes to the gut where it's broken down by the gut bacteria. Number 5, part of it excreted into feces and part of it reabsorbed and goes back to the kidney, and from there gets re-excreted. Better shown out here. So conjugation, bilirubin. Here the intestinal breakdown the conjugated bilirubin into the unconjugated part, urobilinogen, which is the colorless chromogen pigments. And from here what happens? The urobilinogen and stercobilin, part of it to the portal circulation, go back to the hepatocyte, part of it to the kidney, and from the kidneys go to the urobilin. One thing to remember is that urobilin is not the colored compound. The yellow color that you get is not basically the colored compound. The main color is by unidentified urochromes, by oxidation of the urobilinogen, and that ultimately leads to the yellow coloration of the urine. So this is the whole bilirubin cycle. But what is important to remember is that in these, the liver can metabolize 10 times the normal amount of bilirubin, right? Other thing, that this is a very insensitive test. You do a serum bilirubin, you're very happy, the bilirubin is higher, and we decide that more than the normal level, we decide that there's some kind of a liver problem in this patient. No, that's not true, right? So basically, when you're talking about the bilirubin in the plasma, 95%, normal circumstances, 95% has to be unconjugated. The rest of it is conjugated. Normally, you don't have too much of unconjugated. And unconjugated cannot be excreted in the kidney. Remember, why is fat soluble? It cannot be filtered in GFR. So if you're finding bilirubin in a urine, be sure of one thing, that your conjugated bilirubin is more in the plasma, more than the normal level. So bilirubin in the urine can mean only one thing, and that is the level of conjugated bilirubin in your blood is higher than the unconjugated. Is that clear? No bilirubin, it's normal, unconjugated. The moment bilirubin appears in a urine, you're having some kind of a conjugated bilirubin problem. And that is most commonly called obstructive.
Sorry to sir, we are not.
Now I've removed this. There must be something wrong with the Google.
Sir, name Kotaditya Raj 57. Someone simply put his mic on. We are not
No,
getting the audio.
I have not unmuted. So you have muted yourself. So something wrong with.
Yes, someone named Kotaditya Raj 57. He's constantly put his mic on. That's why we are not getting the audio, sir.
No, I have not put the mic on. I have not put that on. I have not unmuted you. You must have done. Not muted anybody. So if there's something wrong, I think there should be something wrong at your level. Because at my level, I cannot mute all of you. So I've requested all of you to mute yourself. The rest of you are getting the mic. Hello, hello, hello. Anybody? Can you get the mic? Can you hear me?
Yes,
Yes, sir.
sir.
Yes, sir. Yes, sir. Yes, sir.
Okay. Then there must be something wrong with the mic. Can you call it? Am I now? Can I continue? Can you hear me? Hello. Hello. Not audible to anyone. Not audible to anyone. Hello. Am I audible to anybody? Nobody can hear me. हाँ क्या साउंड नहीं आ रहा? हाँ. Has anybody kept the mic on? I don't know what the question.
Sir,
Yes, sir.
kindly
Kotaditya Raj
all participants.
57. Someone named Kotaditya Raj 57. He has put his mic constantly, sir.
No,
On.
can you
That's why.
switch off your mic, please? I don't know what's wrong. If my mic is on, अब आ रही है?
Yes, sir. You can mute all the participants.
हो जाता है. चलो मैं देख. Let me see. Let me see. KRS. नहीं हो रहा है, वो माइक नहीं हो रहा ना. Now can you hear me?
Yes, sir.
Yes, sir.
Now you can hear me?
Yes,
Okay,
sir.
okay. Okay, so we're talking about the gallbladder function. I'm sorry for that. I think anyway, so we'll talk about that later. So the difference between the gallbladder function of a liver bile and a gallbladder bile is basically its concentration. So you look at the concentration between the liver bile and gallbladder bile, 98%, 92%, and that's why it ultimately leads to about 6 to 10 times concentration of the bile when it is stored in the gallbladder. The liver bile is converted into the gallbladder bile. The two things are happening. Number one, there is alteration or concentration of the constituents because of more water absorption, and at the same time, the pH changes from 7.58 to almost acidic. So the gallbladder bile is slightly more acidic as compared to the liver bile. Okay, more acidic than that. So that there are two important things occurring in the bile, which is happening in the yeah. So what are the functions of the gallbladder? Number one, reservoir, and that is very important point practically when we are doing lab cholecystectomy or standard cholecystectomy, and we do a cholecystectomy and we find suddenly jaundice creeping up, and then we don't know how much jaundice should be there in a patient who has had cholecystectomy. Now look at it. The bile, the gallbladder acts as a reservoir. So with gallbladder present, if you're ligating the CBD, the damage to CBD, and your gallbladder is in place, your bilirubin should start rising only on the second day. Is that clear? But if your gallbladder has been removed, after 6 hours, the bile starts, the bilirubin starts increasing. So this is a practical point should be kept in mind. That after cholecystectomy, if there's been any damage of CBD or accidental ligation of CBD, your bilirubin start rising within 6 hours. Whereas a patient who's got a gallbladder in and the CBD is ligated, there the bilirubin will only rise after 48 hours. That's an important consideration. Is that clear? Number two, changing reaction of bile. I already told you that becomes slightly acidic. And the gallbladder has a secretory function. What does it secrete? Number one, mucus 20 ml per day and calcium by the inflamed mucosa. Okay. So in a patient of gallbladder, the bile, number one, bile concentration, sodium chloride actively absorbed, water passively absorbed, potassium, calcium absorbed, bicarbonate absorption to a certain extent, and results 6 to 10 times concentration. This we already talked about. Now, what happens in obstructive jaundice? If you remember this, it will give you a clear picture of any kind of jaundice. So the total bilirubin is positive, mainly the conjugated bilirubin plasma. We all know that obstructive jaundice, the conjugated bilirubin rises. Number two, so that means the bilirubin now will appear in urine. Why? Conjugated is water soluble. Water soluble, it will come down into the urine. Agreed? Very clear. Not very difficult. If you remember it that way, you can remember. You don't have to memorize. So conjugated bilirubin would be water soluble and would appear in the urine. Clear? So now you'll have bilirubin in the urine of a patient obstructive jaundice. Now none of it is coming into the intestine. Why? Because the CBD is blocked either partially or totally. So if nothing is coming inside the GI, no urobilinogen is being formed. Why? Because only when it comes into the GI, only then urobilinogen gets formed. So the stool doesn't have any urobilinogen. The urine does not have any urobilinogen, and nothing in the stool. Why? Because for the simple reason that no urobilinogen is being formed. So very clear. Number one, conjugated bilirubin rises. Urobilinogen is not in the urine, it's not in the stool, and bilirubin rises in the urine. Very simple. And that is how you make the difference. So the overall profile in obstructive jaundice, number one, conjugated bilirubin is increased. Number two, the urine bilirubin appears. Why? Conjugated water soluble. Urobilinogen will be absent. Alkaline phosphatase is raised, almost up to 5 times the upper limit. Could be that level. Gamma glutamyl transpeptidase is a sensitive marker and is raised. 5-nucleotidase is raised. ALT, AST may or may not rise. Albumin is decreased. PT, prolonged INR ratio increased. And renal function tests may be impaired. So all these things, you have to remember when talking about obstructive jaundice, all these things will be visibly aware. And that's why the biochemical differentiation, you don't have to go and memorize this. If you remember what's happening, you can easily know what is happening in this patient. Because we already talked about the obstructive jaundice, what we already said, that the urobilinogen will be absent. No, because not being formed at all. Serum conjugated, right? Is right. The urine bilirubin appears, high colored, conjugated. Here conjugated, right? So fecal stercobilirubin absent. That's why you get a clay colored stool. One thing you need to remember is that when you have a clay colored stool, there's one thing other you need to remember is that when you have an obstructive jaundice for a prolonged period of time, that is part of the physiology. Need to know that if you have obstructive jaundice, high level obstructive jaundice for a prolonged period of time, your stool becomes yellow color. I would say how yellow colored? You're just now saying the CVD is blocked, no urobilinogen formation, and then you're saying yellow colored. That is explainable. The explanation is that when there's a rise in the bilirubin, conjugated bilirubin, it goes and all the cells are laden with this bilirubin. Now, the most rapidly shedding cells and multiplying cells are the GI and the skin cells. Now, when the GI epithelium sheds itself off, what's going to happen? When it sheds itself off, the cell dies, it releases the bilirubin. So it is that bilirubin which comes and gives the color to the stool. So nothing is coming through the CBD. No, it's not. What is coming into the CBD is basically the release from the cell of the lining of the endothelium which has been destroyed. Is that clear? So prolonged obstructive jaundice, clay color stool may not be found. It would be basically a stool which is yellow color. Now, the most important function of bile apart from that is basically what? The micelle formation. And how do you find the micelle formation? This is basically negatively charged all around, and it is basically lipophilic. That's why we say bile salt is amphipathic. It's got both the negative and the positive. So here inside the micelle, it will house what? The cholesterol and the fatty acids. And outside, so this is basically fat loving. And outside the negative charges, they basically keep it separate from another micelle. And what helps in the separation? Lecithin. So the interior part of the bile salt is lipophilic. So it basically houses, and in the interior is a small lipid nucleus of glycerol and fatty acid. And lecithin expanded this bile salt micelle, and they keep separate, and they are in suspension. That is how they keep the fat in suspension, help in the digestion of the fat. What else is the function of bile? Number one, we already said dissolving the cholesterol, and the ratio is to be remembered. The bile salt to cholesterol ratio should be 25:1. Anything less than that, precipitation of cholesterol. Why? Because the micelle formation is defective. It activates the pancreatic lipase, neutralizes the gastric acid in duodenum, antibacterial property. And in addition to this, two things are important. It stimulates the increased energy expenditure and stimulation of GLP-1 release. These are all features of functions of bile. This basically function is now known because it forms an important aid in the diabetic surgery, helping in the diabetic surgery, right? The gallbladder emptying, we already talked about that, what retards and what helps. I'm not going to repeat that. The pressure relationship, we already talked about that, right? Now coming to the last part of today's lecture, that is the investigations of gallbladder pathology. And what are the investigations? First, let's talk about the plain X-ray of the abdomen. You say it's absolutely useless. Why advise a plain X-ray of the abdomen in a gallbladder disease? 15% of stones are radiopaque. We know that. 85% are not. Only 15% you can see on a plain scagogram. But it can give you a lot of other information. First is a radiolucent gas trapped inside a stone. And what do you get in that case? You get various kinds of signs. Mercedes-Benz sign. Can you see this sign? The triradiate sign. This is the Mercedes-Benz sign. So Mercedes-Benz sign. Or it could be just a flying wing sign, what is known as seagull sign. You can also get an emphysematous acute cholecystitis. What do you find? The champagne sign. What is the champagne sign? The champagne sign, yes. See this. It's just like a gas bubbles in a champagne bottle. Can you see this? So this basically, can you see these gas bubbles coming? The gas bubble. See. So that is the emphysematous cholecystitis. You get the champagne sign on the plain scagogram. This is a Mercedes-Benz sign, right? Let's come back. Gas in the bile ducts. Pneumobilia. Inside the gallbladder, it could be inside the common bile duct, it could be there even inside the intrahepatic channel, biliary channel. See this? Can you see this shadow? That the cancer, the CBD. So that is pneumobilia. So it is not only the stones of 15%, you can have a lot of other information on a plain scagogram of the abdomen. But air trapped inside the stone, or the trapped inside the CBD, or it could be trapped inside the intrahepatic biliary channel. You can have opacity of the gallbladder. Like, for example, in this case, can you see the opacity of the gallbladder? No test has been done. There's nothing but a porcelain gallbladder. It's a porcelain gallbladder, right? So you can get opacity because of excess calcium inside the gallbladder, what is known as a paste of calcium, also known as the limbal bile. And what is limbal bile? Limbal bile is nothing but a paste of calcium carbonate and calcium phosphate. Porcelain gallbladder I just now showed you. Why is it important? It's pre-malignant in 5 to 10% cases. Initially, we believe 60%. I told you about this in carcinoma gallbladder, right? Now, why is it called porcelain gallbladder? Because peroperatively, when you open these gallbladders, when you open the abdomen, they appear as blue discolored, brittle consistency gallbladder. That's why the name porcelain gallbladder. On a plain skygram on an ultrasound, you find this calcium incrustation and a lining of calcium all around the gallbladder. In addition, you also find a sentinel loop. What is a sentinel loop? It is basically a permanent loop of intestine diagnosed on the basis of a gas shadow. So you'll have a gas shadow in a segment of bowel. Usually seen with what? Acute pancreatitis. There is a jejunal shadow out there. That is again a sentinel loop. Here in a patient with acute cholestasis, what is lying in close proximity to the gallbladder? Transverse colon. So you can get a small segment transverse colon with air trapped inside because this paralytic ileus on either side. The central part of the gas expands the transverse colon. It is collapsed on one side, collapsed on the other side because paralytic ileus. So that gives a segment, a transversely lying segment of gas shadow. Right? So this is basically, I just want to show you the AXR. Now, what is the ultrasound? That's the gold standard for gallbladder diseases. 96% diagnostic for gallbladder and CBD pathologies. What can I tell you about the gallbladder? The size, the wall thickness. If it's more than 3 millimeters, it is problematic. Remember that. Gallbladder thickness, wall thickness more than 3 millimeters. It can diagnose stones for you. It can diagnose polyps for you. Extrahepatic biliary channel, especially the supraduodenal part. And CBD should always be less than 6 millimeters. So these two things are to be remembered always. A diameter of CBD less than 6 millimeters is normal. Anything more than 6 millimeters is abnormal. And number two, a gallbladder size, wall thickness of 3 millimeters. These are important parameters. Pancreatic head, cyst can be diagnosed. Porcelain gallbladder, you can see a thin rim of calcification. Acute cholecystitis, what are the signs that you see on ultrasound? Number one, you may see a pericholecystic collection. Just note these down. This is an important finding in ultrasound. Ultrasound Murphy sign. Basically, Murphy sign you all notice is the rebound tenderness found on the right hypochondrium. Now, instead of using the finger, you can do the same thing with the ultrasound probe. That is the ultrasound Murphy sign. Hydrops. Hydrops basically tells you what? A distended fluid-filled gallbladder. Now, hydrops basically is what? Enlarged gallbladder and non-compressible. That is the hydrops of the gallbladder. So with the probe, you cannot compress it. It is why? Because the mucociliary empyema has already formed. You can see impacted stone in the neck. You can find evidence of Mirzie's syndrome. We'll talk about Mirzie's syndrome is in the next lecture. Emphysematous acute cholestasis. You see the champagne sign out here. So these are all signs which suggest that probably the patient has got acute cholestasis, correlate with the clinical findings and come with the diagnosis. A stone disease can be diagnosed by what is known as the WS sign or triad, wall, echo, shadow. WS stands for wall, echo, shadow, triad. And that is the typical feature of a stone inside the gallbladder. What is the wall? A well-defined near wall. That means one edge of the gallbladder is lying nearer to the probe. So that is a well-defined near wall. Then beyond that, what is lying inside the lumen? You find the stones immediately beneath the wall. And then you find strong echoes of stones in the gallbladder fossa abutting the liver. So you have the stones emitting some kind of sending those signals back which are lying in the lumen, and different signals when they're lying in opposition to the liver. So that is why the wall, echo, shadow, triad. You can easily diagnose a gallbladder growth, and all sites are seen on plain skygram can also be confirmed on an ultrasound, right? So these are some of the ultrasound images that you find. Now see the thickness of the wall. It's about 11.3 millimeter. A pathological gallbladder, right? This is a mass inside the gallbladder wall, mass side, and this is basically the WS sign. The three. One, the wall nearer, then you got the stones out here, and then you got basically reflecting from the liver. So the WS sign. Now, what about the other investigation? Isotope scanning. And which isotope scanning? The HEDA scan, the PIPITA scan, right? Now, the dye is injected, tagged with 99 technetium. Dye is injected CBD injected, and when do you see the various parts of the hepatobiliary channel? The CVD can be seen within 5 minutes. That's very important. The duodenum 10 to 15 minutes. And you would expect the gallbladder should also be seen 5 minutes because the CVD is seen 5 minutes. No, sir. The gallbladder is seen 90% after 30 minutes and 100% 1 hour. That means the dye to concentrate inside the gallbladder takes the longest time, and a time equal to the time of appearance of the dye inside the bowel. So remember, dye appearing in the intestine and dye opacifying the gallbladder, both will take 1 hour. Immediately the dye goes into the liver, gets excreted into the CBD within 5 minutes and 10 to 15 minutes. Small bowel 1 hour and gallbladder 1 hour. Is that clear? So don't give the impression in mind that the route intake would be liver, then the CBD, the gallbladder, then the duodenum. No, it is not that way. It is the liver, the CBD, the duodenum, and then only it goes to the jejunum and the gallbladder. Right? What does it indicate? It is a good investigation for acute cholecystitis where there is a non-visualization of the gallbladder even after 25 minutes. Why? Because 90% of classification should have been seen in 30 minutes. So if 25-30 minutes you don't see any gallbladder, that basically means there's some kind of a block at the neck of the gallbladder. After all, that is the route the dye is going to take. From the CBD is going to go into the gallbladder through the cystic duct. You block cystic duct, no dye inside the gallbladder. Demonstrate the patency of an enterobiliary anastomosis that you have done. And it also tells you about the post-cholecystectomy leaks, although it's not the favored investigation for post-operative leaks after post-laparoscopic cholecystectomy. CT scan, better definition of CBD stone, malignancy, role in defining gallbladder cancers, very good. Why? It tells you about the lymph nodes and tells you about the liver metastasis and mets elsewhere, hepatic pancreatic lesions, lymph node status. CT scan is a very good method investigating. MRCP or MRI directed scan of the hepatobiliary system. It equals the result of ERCP and PTC. PTC is percutaneous hepatic cholangiogram. And you're not doing any intervention. It is purely MRI scan. So that is where it scores over ERCP and PTC. But there is one disadvantage, and that is that it cannot take a biopsy. That is the only place where ERCP scores over MRCP. It defines the whole extra hepatic biliary channel, the intrahepatic biliary channel, and it tells you the whole anatomy. And then comes the PTC or percutaneous transhepatic cholangiogram. How is it done? It's basically done by putting in a needle in the 9th to 10th intercostal space in the mid-axillary line. And you have to have certain prerequisites done. Number one, you should be having a normal coagulation profile. And number two, the serum bilirubin should be more than 9 mg/% to have a very good PTC scan. If it is not, the peripheral cholangioles are not dilated enough for the needle to go into these cholangioles. Until you have that, the cholangiole cannot be cannulated or punctured. Once it's punctured, then you can inject the dye. So you have to puncture one of the cholangioles, and that is only possible if the serum bilirubin level is more than 9 mg/%. So remember, serum bilirubin more than 9 mg/%, normal coagulation profile. It is a blind procedure, or it could be fluoroscopic ultrasound guided. You can see on the ultrasound, it will tell you where the needle is going. Or you can just do it as a blind procedure by pushing the needle in and out. Wilms needle, that's one of the good needles that you can put in. 9th and 10th intercostal space, the mid-axillary line. It is basically diagnostic. It could also be therapeutic. Like for example, if you have any kind of block at the porta hepatis leading to a jaundice, you can the dilated intrahepatic channel, you can push in a pigtail catheter and you can drain the whole bile. So like for example, in Klatskin's tumor, it becomes a method of therapeutics, temporary therapeutics. Other investigations, ERCP, diagnostic and therapeutic, nothing to speak about that. Peroperative cholangiogram is another method. You're doing some kind of a surgery, you're not able to dissect the callous triangle. What do then? You basically take the elbow peroperative cholangiogram. But this is one investigation which is touted to be a very good investigation, but unfortunately, it is not caught up with anywhere in the world. Nobody now does it as a routine in peroperative laparoscopic cholecystectomy. Nobody does it either in open or in laparoscopy. But the basic thought behind it was that if I'm not able to identify the common bile duct and cystic duct while doing some kind of laparoscopic surgery, I am liable to damage the CBD. Let me do a peroperative cholangiogram. The problem is it's a very, very difficult procedure to do when you're doing when you're doing it during surgery. So peroperative is not an easy method, and the results are not standard. So even after doing it, you'll not be able to tell what you're doing, what you're doing. And that is why a new investigation has come on the block, and that is peroperative ICG-NIR. ICG is basically the dye, and that is indocyanin green dye, and NIR is near infrared spectrum of light. So this basically near infrared spectrum light is caught by the ICG, the dye, and then that is caught by a NIR camera. You can see that fluorescence. That fluorescence is what? That is basically fluorescence of the NIR light absorbed by the indocyanine green ICG. So this is one of the methods which is now gaining more and more grounds. Why? Because this tells you without doing anything, you just inject. You're not cannulating the CBD. You're just injecting something, a dye, through the vein, through the venous route, and within 25 to 30 minutes, it will directly go and opacify the whole of the biliary compartment. So 20-30 minutes after the injection, it is excreted exclusively by the liver. It doesn't go to the kidney. And if it is exclusively by the liver, it gets enough concentration of the extrahepatic biliary channel. And so by intermittent putting on the camera, you can see what you're doing and where the dye is. You can easily separate the corn bile dye. So it forms one of the better methods of doing it. Although, let me be frank, it is still not caught up with most of the laparoscopes. Why? Because you have to have a different kind of a telescope. The dye is costly and the results are not standard yet. Okay. The other method of doing it is the T-tube cholangiogram. You can easily delineate the whole of the extrahepatic biliary channel. You have done a CBD exploration, you put in a T-tube. Now that we'll talk about when we talk about the CBD storm. So you put in a T-tube, and before removing the T-tube, you have to inject a dye inside the CBD. Why? Because you want to see if there's any remnant stone remaining behind. So T-tube cholangiogram is another investigation for the hepatobiliary compartment. And then a debatable role of FNAC. It is good if you want to see for the liver mets, but just doing FNAC for gallbladder lump supposed to be malignant is probably not still advisable, but ultrasound guided, CT guided FNAC of a lymph node, suspecting it to be a mets from a carcinoma gallbladder, that is one thing which is being done, right? So the FNAC has a role in doing FNAC of the lymph node rather than FNAC of the gallbladder, although it has been advised by a number of persons now, especially in those cases where the whole thing is full of a growth. Otherwise, what's going to happen if you do FNAC of gallbladder? The bile is going to leak out. But if the whole thing is filled with a growth, just taking it out would basically, doing FNAC would be slightly safer than that, right? I think that finishes the lecture. Oh no, one more thing. I just have to mention the two redundant investigations which were very favorite investigations before. One is the OCG, or the oral cholecystography. That I just mentioned because I think nobody does it anymore, or IV cholangiogram. IV cholangiography and oral cholecystography. I just mentioned it because you have to know what they were. And these were basically, this was done by taking tablets of telipig. These were tablets which are taken 3 grams, 500 milligram, and you used to take 6 tablets. And IV cholangiogram was basically intravenous dye. And both of them, this was basically for delineating the gallbladder. The IV cholangiography was basically for delineating the extrahepatic biliary channel. Now, the problem with oral cholecystography with the help of the tablets was there were so many variables, especially if you have got a bad stomach, you got diarrhea. None of the tablet will be absorbed into the circulation. So you take the tablet and it goes off. So no specification of the gallbladder, and you misrepresented it or you misinterpreted it as a non-functioning gallbladder, and you remove the gallbladder, finding it to be absolutely normal. So the misinterpretation of this test was so huge that it gradually fell into disrepute. 80s, we used to do this. In came the ultrasound in 85, and everybody forgot about the OCG, right? Similarly, for IV cholangiogram, you came up with the HEDA scan. So IV cholangiography is also given up. Nobody does the IV cholangiography. It basically was indicated at that time when you could not take a telefake dye. So these patients were given this IV cholangiogram, the dye for taking IV cholangiogram. But now no more done because this was basically just for duct visualization. And you got so many investigations now for duct visualization. So nobody does the IV cholangiogram. So these I just mentioned, the oral cholestogram and IV cholangiogram, because they were investigation which was done not in too recent past. 80s they were done, but now no longer done. Is that clear? Right. So that is the end of today's lecture, and I think day after tomorrow I'm going to take the rest of the gallbladder lecture for the undergraduates, and I think the same time I'll be sending you the connectivity and the site where you have to go in. Right. Any questions now? If you have any questions, I'll be willing to answer them. They go and read up in the book, and I think you'll come up with the answers. Okay. Okay. Thank you.
Thank you, sir.